Apa?
Hai, Dato, tak pernah lambat. Untuk sentiasa awal 10 minit. Saya nampak tak beradab?
Assalamualaikum, Dato. My friends already are here. There's one more coming. And if you are ready, you can start the class. Thank you.
Semua ada dah?
Yes,
Semua
all
ada
are
dah?
here. Yeah.
Go. 2 minit lagi, tunggu jap.
Okay, sure.
Budak sipet tu macam mana? Okey. Dia pakai yang mesin baru tu. Tapi yang orang pakai pun bukan mesin baru semua. Okey kan mesin tu. Emas ada kan? Emas ada banyak. Emas harga beli semua banyak emas tu. Emas baru tu emas lama je pakai. Emas. Yalah, maksud saya masuk main ni emas kita beli tu kan. Kita apa? You pakai mesin N tu kan, N ni komponen tu kan. Okey mesin tu. Ya, soalnya suatu kali dah nak beli lagi mesin tu. Apa tahu umur apa? Baby umur apa? Oh, kalau bayi tak perlu pakai baby. Kalau ada one itu pertemuan sebab ya tak perlu. Ada lecture budak ni. Y5B3 dia lecture banyak lecture Y5 tapi space side banyak lagi. Macam saya ambil kita tak ada siapa nak beli. Dia seorang ada lecture note lagi. Kita tak ada nak buat lecture note baru. Ya. Yalah saya banyak dah ambil 5 teaching. Tak biar. Dah cukup lagi lah buat duit lagi tu. Baik kita laju daripada sebelum. Masa I dulu sampai 4 bulan 5 bulan. Sekarang ni dengan prof ni dia make sure saya beritahu dia dah kalau mengajuk mati kita. Kita tak raya, dia pun tak raya dah. So, tak tahu siapa boleh gaji nanti. You pujuk lah mak tu. Aku selalu tu aku boleh pujuk tapi mosak tu you pujuk lah elok. Okey. Semua dia tak nampak muka kenapa? Oh, kita buat instruction semua muka kena nampak. No awatif mana muka? Semua ada dah. Lali, Safi,
Yes. Semua ada.
Alfina, Faiza, Akil, MS. Siapa ni bawah ni? Tak mandi. Husna, Alia, Fawaz. Siapa ni? Siapa? Hazrin, mana muka? Hasanah. Hasanah mana Hasanah? Is instruction is can tell all the fields first before we can start all the teaching. Husna. Hazrin, mana Hazrin? Bukan pakai tudung. Hazrin mana Hazrin? Hazrin. Hanif. Alisa, mana Alisa muka? Itu muka Hazrin tak nampak lagi. Husna nampak muka dah tadi? Husna? Hazrin mana muka dia? Kata dia consider tak datang tau. Hazrin? Hazrin mana?
Dia toilet. Toilet. Azrin dekat toilet.
Weh, kamu lah mengarut je lah pukul 12 lecture pun pergi toilet. Mengarut tu mengarut, tak mengarut. Itu mengarut tau. Bukannya you tak boleh pergi toilet sebelum tu. Lecture bukannya, baca 45 minutes je. You think I tak pernah jadi student ke? Bila tak nampak muka dia, aku sedih tak datang. Come, start. You nampak slide ke? You all can see the slide?
Yes, nampak.
Sini lah, okay dah. Okay, I'm talking about respiratory distress in newborn. So by the title already, by right, you all can figure out what is it. It's a respiratory distress in newborn. With respiratory distress, you all know what is respiratory distress. Newborn ni yang baru lahir lah, anything who just been born. We're talking about baby who just been born, not animals, baby. So as I said earlier, it's about newborn and respiratory distress. I mean that when baby come out, they're having a difficulty in breathing. You all notice, look like the baby, they're having difficulty in breathing. And this is one of the commonest cause of admission to an ICU, newborn ICU or in a special care nursery. Causes are a lot. Causes are multiple system. Respiratory distress show you there is a problem, which means that difficulty in breathing. What the causes? There are many possibilities and involve many systems such as respiratory system, cardiovascular system, central nervous system, musculoskeletal system, and even metabolic. So there are many systems, but we're going to focus on respiratory, cardiovascular, and some CNS and so on. So you can find out, you can have some figure out, you can roughly figure out the commonest causes. So as you look here, the causes is from respiratory disease. Anything that affect the respiratory system can cause respiratory distress. From airway obstruction, can be nasal stenosis, Pierre-Robin sequence, vocal cord paralysis, vascular ring, colonial atresia, laryngeal stenosis, hemangioma, tracheobronchial stenosis, or disorder of chest wall or and diaphragm, like disorder of chest wall, congenital diaphragmatic hernia, example, or malformation of mediastinum and lung parenchyma, such as congenital cystic malformation, adenomatoid malformation, CCAM, or congenital pulmonary cyst, neoplasm, congenital lobar emphysema, pulmonary AV malformation, BPD, bronchopulmonary sequestration, Ehrlich syndrome, such as pneumothorax and other pneumomediastinum, pulmonary parenchyma, vascular disease, such as all possibility. This one is more important for you if talking about newborn. Johnson trachea of newborn, meconian aspiration, Halley membrane disease or RDS, pneumonia, congenital pneumonia, and so on. And then, okay, I give you the possibility, the causes, but the most common is you look into the one that I'm going to present later is related to the most common. The cardiac disease also can cause difficulty in breathing, such as bronchiolitic heart disease, because of inadequate oxygenation, such as transposition of great arteries, total anomalous pulmonary venous return, Epstein anomaly, tricuspid atresia, pulmonary stenosis, Dato and severe congestive heart failure, or asymptomatic heart disease for hypoplastic left heart syndrome, interrupted aortic arch, critical aortic coarctation or pattern PDA, or it can be neurological disorder. So many causes. Brain trauma, IVH, meningitis, ischemic, hypoxic ischemic encephalopathy. From there, you know it's a burst asphyxia. Pulmonary seizure disorder, obstructed hydrocephalus, infantile botulism, very rare. Spinal cord injury also very rare, and other miscellaneous. This one quite common. Sepsis very common. Anemia or polycythemia are fairly common. Hypothermia very common in the newborn. Hypohypernatremia, hypoglycemia, inadequate glucose, or even error metabolism, IEM. So there are multiple causes. So there are many causes of respiratory distress or difficulty in breathing in newborn. Many causes. So, but for you, the most important is ability to recognize. So you have to be familiar with respiratory sign and symptoms. What sign you want to look at. And when you look at the sign, you have to decide, is it mild, moderate, or severe? When it's just tachypnea, tachycardia, you can say, oh, probably child is mild only. If the child is having subcostal recession, LNSA, it can be moderate. If you can sinus, grunting, drowsy, comatose, then you know the child is having severe respiratory distress. So you have to decide when you look at the sign and symptom, is it mild, moderate, and severe, then and you must recognize it. As a doctor, you must able to recognize it. This is the child having respiratory distress. The other signs which is not that specific, such as poor or not tolerate feeding, inactive, poor perfusion, hemodynamically unstable, stridor or wheeze, listless, and temperature instability. There are the other signs. So treatment-wise, very straightforward. You always airway, breathing, and circulation. Secure the airway. Suction, position the bag. Mask, intubation. I mean that you secure the airway first, then breathing using the bag and mask, or if necessary you intubate the child. Look at the circulation, blood pressure, and perfusion, and treat the specific causes. Then you have to do, you must know do how neonatal resuscitation. So little bit about anatomy, and you see the neonate or newborn airway or lung start from nasal cavity, pharynx, epiglottis, larynx, trachea, right lung, left lung, bronchus, pleura, diaphragm. That is basically, and in terms of more deeper microscopically, you look into the microscope, bronchioles, alveolar sacs, and alveolar. Alveolar sacs and alveolar. So you look at that. For that is a respiratory system, basic respiratory system. And a little bit about the respiratory system. When talking about newborn, you have to understand a little bit about their system development. Just to know about it. No need to memorize it. Started from embryonic phase, 3 to 5 weeks, pseudoglandular phase, 6 to 12 weeks, 16 weeks, canalicular phase, 17 to 24 weeks, alveolar phase, 24 weeks, alveolar, 8 weeks, 8 years, and size. I mean that this is the phases until 24 weeks. And then when baby being born, the alveolar development, still the new alveolar still form until age of 8 years. Then, but then it stopped. No more new alveolar being produced, but the size and diameter of the airway continuously until you reach adult. Usually at the female, the 18, 19, for male 21, 22, when they stop in the size and diameter. That is the respiratory system. Bit more in terms of you look into the longitudinal in terms of time factor from week 2 to 38 week, and then the phase from the first embryonic phase, where is a bronchi, pseudoglandular bronchioles and terminal bronchioles, canalicular respiratory bronchioles, circular alveolar ducts, and there is the time factor, week, temporal time, temporal according to temporal line. For 2 weeks, 4 weeks, 6 weeks, 16 weeks, and canalicular at the 24 weeks, and then circular phase. This is the most important factor, that 25 week when you have to have surfactant. Surfactant is very important chemical in respiratory system in order to have the blood gas exchange. Surfactant started at the age of 26 weeks. That's why before 24 weeks, usually the baby is difficult to be viable. When we born, when the child being born is not viable. You have to give surfactant if you can. You try to help them. 24 weeks and below, because you need surfactant to live. So surfactant, we're going to talk a little bit more about surfactant. So there is the filter period. Inside intrauterine, there is the embryonic period. So then little bit there's when the embryonic formation of major airways, pseudoglandular formation of bronchioles and acinus. This is during agonogenesis, and then the start after agonogenesis with differentiation, which is develop canalicular phase, circular phase, which is development of the new lung tissue, epithelial differentiation, and then expansion of airspace, and then surfactant detectable in amniotic fluid, and then further on later on is the lung usually mature properly at the 36 week intrauterine, intrauterine 36 week. That is where the lung is naturally fairly mature to be exposed to the extrauterine life. So we go one by one. The most common is RDS, respiratory distress syndrome. I think you heard about it. It is because surfactant deficiency. As you can see, surfactant developed 26 weeks, but it can be detectable by 24 weeks already. And then with surfactant deficiency, surfactant is phospholipids. Without surfactant functions to prevent the alveoli collapse, airway and alveolar collapse, both. So without it, the alveolar can collapse. The risk factor of surfactant deficiency are prematurity, male sex, perinatal asphyxia. I mean that during the baby deliver not enough oxygen, maternal diabetes, antepartum hemorrhages, and cesarean section. Diagnosis is X-ray is adequate. Using chest X-ray is adequate to make diagnosis. Management is respiratory support, including ventilator. If you need to give a machine ventilator, we give ventilator. Fluid balance, make sure that the baby have adequate fluid, electrolyte is normal, and acid-base balance is normal. And then we give antenatal steroid for the cases we think this one can, if we think we can help the baby to, because antenatal steroid can enhance increase the production of surfactant in the lung intrauterine. And after delivery, if the child we suspect having surfactant deficiency, we give surfactant replacement. So the function of surfactant is that this is the alveoli, so it maintains the alveoli integrity. By increase the respiratory compliance. Second, reduce the tendency of alveoli to collapse, prevent the collapse. So how you do it? By affecting the surface tension. The surface tension, where the surface tension is the interface between the air and the fluid. In alveoli, that is where the surfactant work. Here. So it maintains the integrity of the surface tension, and then as a result, the alveoli do not collapse. Without this, without surfactant, alveoli will collapse. So it's produced by type 2 cell surfactant. So this is what happened if the lung didn't have proper surfactant, and it will collapse like that. It was solid lung like this. Then we call it as a liver-like lung. The lung is nothing. There's no, the alveoli collapse totally, and you see the lung like a liver. So there's no more air space, and this lung is dysfunction. And no way the newborn can survive if the lung is like this. So this is the X-ray. Usually by X-ray, we can adequately diagnose. You can see the whole consolidation of the lung, and you can only see the air bronchogram. The lung consolidate, whitish. This is type 3, type 4, sorry. And then if case like that, sometimes we need to intubate the child, put on the ventilator, and then try to support the child until the body able to produce the lung, the surfactant by itself. And during that time also, we give the artificial surfactant. There are many artificial surfactant, either it was from animals or we produce it in the lab. This Savanta is organic, for animals. The other one quite common in the newborn is congenital pneumonia. Congenital pneumonia, you know, by the topic title itself, it tell you it's an infection. And then its main organism, microorganism is Streptococcus, is the commonest. Other organisms include Listeria, Klebsiella, and then the risk factor is maternal fever, with the mother having fever, and then mother also having UTI. UTI, I mean that the tract is self-infected. And then if there is a chorioamnionitis, immediate the chorion, the amnion fluid are infected, premature rupture of membranes, prematurity, then colonization of the delivery tract or birth canal by group B strep. And treatment wise is antibiotic lah, because the name is pneumonia, so treatment wise will be antibiotic. And then the transmission either by hematogenous from blood ascending from birth canal or aspiration. I mean that when the baby or newborn when pushed down through the birth canal, they can aspirate infected materials into the lung. And the sign and symptoms can be very non-specific. Elevated respiratory tachypnea, retraction, grunting, nasal flaring, increased mucus or other fluid substance in the airway, and then the mucus can be greenish, yellow, hemorrhagic, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, hypoperfusion, oliguria, and cyanosis or central tissue or cyanosis. And then there is the chorioamnionitis, infected of the amniotic fluid and chorion tissue. And this is the X-ray. X-ray is a bit different from the RES because a bit fluffy, more softer compared to the RDS. But this one is severe congenital pneumonia. You can see severe. It's the X-ray a bit more softer. The first X-ray look more granular and solid. The other common one is transient tachypnea of neonatal. Usually occur in large preterm or term baby, rarely occur in the preterm, and but is around 1 to 2% of incident. It's quite common. The pathophysiology are simple because intrauterine your lung contain fluid, your fluid environment. So in order for you to have extrauterine to live extrauterine, I mean the environment that we have now, the lung fluid must be absorbed or come out from the lung. The lung must be clear from the fluid so that the lung can be functional and then gas exchange can occur. But for whatever reason, certain percentage of the baby, it didn't clear fully. There's still residual of fluid that stay inside the lung. So as a result, the lung is wet and the child is having sign and symptom of respiratory distress, such as short nose of breath, tachypnea, grunting, and recession, and when you auscultate, the lot of capitation. But it rarely persists more than 40 hours because most of the fluid will be absorbed by the body after 40 hours. And the main risk factor is cesarean section. It is because that when the child is you take out the baby out from the lung, from the abdomen, and then very fast. So the child didn't have the mechanism of crying, and compression is not there. So the fluid in the lung are not clear. So the X-ray wise is something like this. There is a fluid in the fissure. There is a, that perihyla, finding that perihyla, which tell you that lung is wet, and the main important is fluid in the fissure there. And then the other one is the meconium aspiration syndrome, MAS. You see, intrauterine, there are a lot of secretion or fluid or tissue or a lot of fluid, and then materials inside your GIT tract, and this GIT tract usually didn't come out, intrauterine, usually didn't come out, except certain condition. Let's say patient having distress inside intrauterine, and due to that you can have a hello. Salam here. Yeah. You can accept her. Yes. Yes. I think you speak tough for you because you got under 1 kilo, less than 1 kilo. What I mean is that no. You how do you have how many baby you have there now? So you can cope or not? If you cannot cope, you say cannot lah. If you got one baby or this is under grammar, is it how many ventilated baby? 2. Then you have one more KIV coming, is it? So you think you can cope another one? You know we try, the suffer will be the MO. Because suddenly you got 4 ventilator, you don't complain to me not enough MO. Because the MO number have that, that's all you have. Don't ask me MO anywhere because we don't have enough MO. So you must plan it properly. If you cannot cope, you say cannot cope. Worry suddenly you want suddenly come to see me, they say cannot cope. Now they do 3 on call now. We got 3 people on call now because they are complaining they are busy, they are in. So you don't, if you take this case, you don't come to say to me that you don't have enough MO. I worry of do you have enough people or not to cope? Because 2 ventilators is under grammar some more. Then you say that if you cannot cope, you cannot cope. For time being, if you ask me, you sort out your internal first. I mean that if we support our ONG first. Okay. Okay, so go back again. So the meconium, so usually your amnion free is clear, don't have any fecal material. So what happened for one reason of another? The baby, the newborn, the intrauterine, the fetal pass motion inside the intrauterine, and we contain of the GIT secretion. Then the material that come out, the fecal material, we call it meconium, and then it contain of GIT secretion, epithelial cell and hair, and then this meconium material is quite sticky, and then as you know, inside it can drift around, and the child can aspirate it. The fetal can aspirate it into the lung, and this cause damage to the lung by obstruction or by its chemical inflammation of the lung. So the risk factor can be usually a postpartum baby, postpartum fetal more than 40 weeks, then they tends to because more than 40 weeks, and if you're not careful, they can defecate inside intrauterine. The other one is inadequate oxygen, asphyxiated, and then as a result, the child, the fetal can defecate inside the intrauterine. The future will be meconium liquor, meconium stain of the baby, and there is evidence of respiratory distress. So treatment prevention merely is preventing the fetal to defecate inside the intrauterine. This is the meconium. You can see very sticky, very very not only sticky. It is quite corrosive to the lung. Imaging this is the fetal aspirate it into the lung, so it can cause obstruction, and it can also cause the inflammation, pneumonitis. And this is the fecal material inside the baby GIT system. So they are the pathophysiology are more complex than this. It affect the surfactant, damage the surfactant, alter the lung mechanics, and so on. There are many things about the meconium aspirate syndrome. The X-ray wise is bit specific to them. They look to be hyperinflated, and then you hyperinflated, and then you can see some small fluffy thing. Hyperinflated tell you that there is obstructed of the lung, obstruction of the lung, obstruction of the lung, and some fluffy tissue here. And then the other cause of respiratory distress is pneumothorax, pleural effusion, hemorrhage, and then the congenital anomalies such as hypoplasia of lung, sequestration, congenital diaphragmatic hernia. Okay, anybody can figure out what is this? Look at the picture, study, tell me what is this? Anybody?
Congenital diaphragmatic hernia.
Yes, this is a congenital diaphragmatic hernia. You can see, it is a postmortem. I mean that the baby already passed away, the newborn will pass away. But you can see in the lung, in the thoracic cavity, there is a GIT tract, GIT, and the lung being compressed. Is the lung, and the heart being pushed to the right side, and the lung here also being compressed. So there is a congenital diaphragmatic hernia, and then there is X-ray. Usually you need by diagnosed by X-ray. Is adequate already. You can see on the X-ray, chest X-ray. This is all the air marking of the GIT tract, which on the left lung cavity. And you see the heart being compressed to the right side. There is the, and then also the left lung, colon, and the diaphragm. So there is congenital diaphragmatic hernia. It's due because of the abnormality of there is a defect at the diaphragm. There are many types of defect. This one type of defect result in the GIT organ can protrude into your lung cavity, and they cause compression of the lung, and then failure of your lung to develop, failure of the lung to develop to mature, and as a result, the effect the lung function. This way, it can be small like this, it can be very significant. It can be not. Sometimes we have cases we diagnosed at the age of 10 or 20 years, 10 or 15 years earlier. This one, anybody can figure out guess what is this? Anybody?
Pneumothorax.
You can see there is tension, pneumothorax. It do happen in the baby, in the newborn. All this air inside the left lung cavity. and then the mediastinum will push to the right side. Compressions, compress the airway, and affect the mechanics. As a result, the newborn having severe respiratory distress. This one. Anybody? Can see the chest X-ray. There seem to be some hypodense area here. It seems to be air here a lot compared to other side. The diaphragm is and then the dark. I see the dark region here, and the diaphragm the sternum will push to the left side, and the CT scan and they show abnormal tissue. Very abnormal tissue. This is what we call the congenital lung lobar emphysema. It's dysfunction. This is not functioning lung tissue at all. Just a realized space with dysfunction lung. But they compress push the result in the upper lobe and the lower lobe here fail to expand, and the mediastinum will push to the right, to the left side. This one. Anybody?
Congenital pulmonary hypoplasia.
No, this one you got something a mass here, is it? Very big mass here. This lung tissue here, lung tissue a bit mass here. This called a cyst. This is a lung cyst. Very big lung cyst. Ini?
Hypoplasia.
Yes, you see the lung, obviously lung. This is when you can compare here the lung size here, very small. And then when you note this a very small lung, not vibrant. The other way is airway abnormality. You can see the maritime airway abnormality from stenosis, laryngotrachomalacia. I mean that the weakness of the muscle of the airway easily collapse. When you take a breathing, the airway collapse or fistula. They got so many type of fistula. You can see here. Many type of fistula result in airway defect, and airway cannot function normally to bring air in and oxygen in and carbon dioxide out. Cannot function normally and result in that the child having respiratory distress. The other one common cause is the cardiac. Cardiac can be congenital heart disease, cardiac failure, cardiomyopathy, immediate weakness of the cardiac, persistent fetal circulation. So result in fluid in the lung, pulmonary edema, increased work of breathing to maintain the cardiac output, and then pulmonary, it can be metabolic respiratory acidosis because high CO2, pulmonary hypertension. All this result in impaired function of the lung, and then this result in the respiratory distress. Pulmonary edema, you know, is heart failure. The other is muscle. When muscle, we need muscle mechanics in order to move the lung. Muscle, you need to move the lung. And then you need the muscle. What happened this SMA, muscular spinal dystrophy, muscle. So what happened this one, the muscle? So what happened is the result in the muscle weakness, and you have, when the muscle cannot move, definitely the child will have respiratory distress, but the presentation will be different. They don't have the tachypnea, they don't have the tachypnea, they don't have that thing, but they have very shallow breathing. Example is SMA, spinal muscular atrophy syndrome, where is the atrophy of the spinal cord, and then result in muscle dysfunction. Spinal cord, you need, the signal for muscle contraction is not there, and just the muscle just cannot contract. We are seeing few cases like this. So go back again. Remember, the causes can be due from respiratory disease, cardiac disease, neurological disease. But another one is very important. Is the sepsis, anemia. Sepsis is quite common in the newborn. Hypothermia, quite common in newborn also. And then hypoglycemia is another one quite common. If you delay in feeding, and inborn aerobic metabolism is very rare. And then the treatment wise, always do the assessment, immediate management. I mean that involve the ABC, airway breathing circulation. Then lastly, you treat the causes. Okay, I think that's all for today. Anything else? Okay, anything else? Any question? Any question? Ada soalan tak apa-apa? Your ni ada ke tak ada?
Rasanya tak ada.
Your ada ke, wujud ke, ada ke? Your ni ada ke? Atau somewhere else?
Ada.
Ada. Okay, any question? Jika ada, tak ada lah, beritahulah.
I think so far no, tak ada
No
question.
question. Okay lah, I assume you know everything. Okay, settle. Dr. Syed ada lecture tak? Ada Dr. Syed, ada?
Ada semalam.
Okay.
Ada, baru satu.
Okay. Okay, finish.
Thank you, Dato'.
Thank you, Dato'.